it is my pleasure to introduce our colleague, Prof. Abdulrahman Jazeiah. Prof. Abdulrahman is beyond any introduction. He is Chairman, Oncology Department, National Guard Health Affairs, Riyadh, Saudi Arabia. He is a member of ASCO COVID-19 and the Cancer Registry and ASCO Resource Center on COVID-19. Prof. Jazieh also, he is the principal investigator of a global registry of cancer and COVID-19 in collaboration with ASCO. Prof. Jazieh also, he is the president of the Academy of Lung Cancer. Welcome, Prof. Jazieh. He is talk about the impact of delayed diagnosis and treatment on cancer care outcomes. Welcome, Prof. Abdulrahman.
Thank you, Prof. Ahmed, for the nice introduction. It's my pleasure to be with you today, and I would like to thank the organizing committee for inviting me to talk about this topic. So my presentation outline will be the following: why does the pandemic affect cancer care? Types of impact that we see, magnitude of the impact, interventions and response to the pandemic, and moving forward. I will try not to encroach onto the other presentation because now we have seen multiple aspects that were covered. So I will try to touch base upon the topic that will be mentioned later or already mentioned. So the primary cause for, these are the primary causes and the contributing factors. So there's overwhelmed healthcare system with resources and infrastructure such as ICU, critical cares, but also the other resources such as hospital beds, clinic, imaging, laboratory, and so on. There are patients' issues that are very important. The avoidance of care, patient doesn't come to their appointment, and actual infection of the cancer patient with the virus. There are healthcare providers' issues, oncology and non-oncology, whether they get infection, get overworked, emotional issues, and burnout, and so on. Interruption of supplies, medications, and other supplies. For example, PET scan radioactive material could not be delivered to certain sites, so they could not do PET scan, and so on. Logistics issue, travel bans, lockdown, and so on. And then, of course, the financial issues, whether it's at the national level, healthcare organization level, or individual level. We were fortunate to conduct actually many studies, at a larger scale. Actually, some of them are the largest in the world. And we'll share some of these data. But the impact are two types, either on the existing patients with cancer or the patients at risk of having cancer, or they already have cancer. Patients at risk, like delay in diagnosis of new cases or delay in screening for cancer, as we heard. But the patients with cancer, with cancer already, they have more morbidity and mortality from COVID infection. They have delay in cancer-specific treatment, delays in medical assessments of the disease, delay in surveillance for their patients who are on follow-up, and delay for caring for complication of cancer or its treatment. We forget that patients with cancer have other diseases that they require care. So we feel that if we left the cancer center open, our patients are okay. No, they need medical care for their COPD, for their heart disease, for diabetes, for other things that they seek somewhere else that may also be compromised, and in addition to the stress and emotional issues that our patients go through. I just want to refer you to the recent terrific systematic review done by the BMJ, showing that how delay on treatment of multiple cancers up to 4 weeks may increase the mortality significantly. So, for example, out of 1,000 women with breast cancer, if the surgery was delayed, 4-week delay will be increasing. 10 more people will die. 8 weeks will be 20 more people will die, and so on. So this is significant issues, and you see here in this how in most of the cancer, delay in whether radiation therapy or surgery or treatment does have impact on patients' mortality. So here, breast adjuvant therapy, cervix, head and neck, and so on. There are 7 cancers that get affected significantly, actually, in delay of adjuvant radiation therapy, for example, and we said surgery and then other treatments. So please look up this so you understand that, that we don't have much margin of delay before we're hurting patients. So there are, as I said, 7 major tumors type: bladder, breast, colon, rectum, lung, cervix, and head and neck cancer. Across the 3 major treatments, surgery, systemic, and radiotherapy, 4 weeks delay is resulted in association of increased risk. For surgery, 6 to 8% risk of death increased, for every 4-week delay, and so on. And you see for radiotherapy, 9 to 13 in head and neck, and colorectal cancer systemic therapy. So it's important. So I'll start with our first study, which is the impact of COVID-19 pandemic on cancer care. We were fortunate to lead a major study globally with 356 centers participating in 54 countries across 6 continents, serving close to 750,000 of patients, new patients each year. We conducted the survey between April 21 and May 8, and you see here that the different continents and the contribution of the centers there. There are majority are standalone cancer centers, but there are about a quarter of them part of another healthcare organization. There is a nice distribution between governmental, private, and academic centers, and offer different disciplines. About half of them serve less than 1,000 a year, but there are centers who serve more than 10,000 also. So we have a nice spectrum of cancer centers across the globe in different countries and so on. 88% of the centers reporting facing challenging in cancer care. They reduced the services. More than half of them, they said we did that preemptively. But 20%, they said our system was overwhelmed. Lack of PPE actually is up in 20%. Staff shortage, 18%. And restricted access to medications up to 9-10%. More than close to half of the center, more than 45% of the center said at least more than 10% of our patients missed 1 cycle of therapy. More than 1/3 of the center said they have interruption of cancer-specific care. And 39% they said there is decrease in access to non-cancer, the other medical problem, as we said, related care. And some centers estimated up to 80% of their patients exposed to harm. When we mentioned that early, people say, oh, 80%. And now we are seeing the data actually. And we are seeing that sometimes 80 to 90% of the patients somehow get some kind of harm. So it's a very serious and widespread problem. And those who don't think that their centers the patients did not get impacted, they don't know the full data, because I will show you, sometimes the patient don't show up. It's not you canceling the appointment, it's the patient not showing up. So what are the findings? So we see here, the closure of the centers. Some of them completely closed, but the majority have some kind of reduced workload. Access to cancer medication, some of them have access to many cancer, lack of access to many cancer medications, and so on. Look at the shortage of PPE. I don't have to dwell into that, but these are all related to cancer care. Cancer care is not an oncologist who has chemotherapy has to give. It's totally different now. The pandemic throw a different challenges on us that we have to keep in mind, and there are diagnoses of infected patients among the staff, among oncology patients, outpatient 46%. Sorry, the shift of the curve here for the numbers here, 46%. Diagnosis among oncology patients, 48%. And then you see what are the intervention were done. Launching virtual tumor board in 77%, and 60% saying the virtual tumor board will persist after the pandemic. Launching virtual plus physical clinic in 78%. And again, 55% of the virtual clinic will remain after that. 3/4 of the centers, they performed lab tests near patients' home, and 68% of the centers delivered medications to patients' home. I think this is going to change oncology practice forever, actually. Many of these things will remain, and actually, in the end of the day, maybe a silver lining. Some of them will be silver lining of this pandemic. So you see these centers across the world. We're fortunate in Saudi Arabia to be the lead in this 28 centers from Saudi and other Gulf countries. The future will be doing regional analysis, including the MENA region and the Gulf country analysis and so on. Now, we have another study of patients with cancer response to COVID-19, with more than 3,600 patients enrolled in the MENA region. And you find that 46% of the patients are very worried and 38% slightly worried. So the majority are worried somehow. But look at this. We asked them, if you have an appointment, medical appointment in the next month, would you show up? 20% they said will not show up. And going further into this, actually, there were appointments actually canceled. It's not theoretical questions. 16% per patient request said, I'm not coming. And 25% per the medical team advice. 25% say the physicians cancel the appointment. And canceling even treatment sessions, whether it's chemo or radiation and so on. 12% was a patient request, and 16% was by medical team. And so this study is under consideration. The other study, which we looked at 1,000 oncologists, this is international study, including different continent. And we look at 1,000 oncologists, and we ask them different questions. I'll just focus on how their life and their professional life and family life got affected. About 48% they said they have a negative impact on their mental and emotional well-being. Their relation with negative impact on the relation with co-workers is in 15%. Family relation strains in more than a quarter of them. More than half of them will suffer some financial and income consequences. And about a third of them have impact on their research productivity. So these are very important to know, and there are some risk of attrition and leaving the oncology profession, like you will see in other healthcare professionals, by the way. So now the delivery of cancer care got impact is, and we are going to see, unfortunately, this impact for the upcoming 10 years. There is the initial wave that, related to acute infection, lack of access to acute care, critical cares such as ventilators and so on. And we see that acutely. The second wave will be coming later and be prolonged a bit. Patients with cancer, with disease progression or delayed detected cancer will be coming with more advanced stage, or cancer which missed cycle, patients with cancer who missed cycles of treatment and so on. And then they will be dying of cancer delayed treatment. And then the third one, the third wave, will be paying the price, unfortunately, for this for years to come. Patients with cancer who miss their screening exam, or patients with untreated chronic medical conditions, and so on. So also this was published with the JCO Global Oncology Journal. You can look at the details, and we have many things in that paper from international experts worldwide. Delayed screening, I'm not going to take a long time, but if you look at this, the Cancer Research UK perspective published in Nature recently, 3 million British did not receive invitation for screening, and there is 50% drop in colonoscopy, and waiting for colonoscopy more than 6 weeks is 9 times higher than the baseline. Scotland reported urgent referral from primary care reduced by 70% from their baseline average. Okay, so it's an issue. Delayed diagnosis. In UK, there are more than 350,000 fewer people usually had a referral for fast track, and 3.4 million fewer key diagnostic tests. 35% were performed between March and August compared to the same period from 2019. In one study estimated that within 5 years, there will be 3,000 additional deaths from breast, lung, esophageal, and colorectal cancer will result from the delayed diagnosis and disruption of the diagnostic services. In the US, we're anticipating more than 10,000 excess deaths from breast and colorectal cancer alone predicted over the next 10 years. Interruption of survey, interruption of cancer treatment. Now we move to the treatment. So we talk about screening, diagnosis. Now we come to the treatment. In the UK, the survey of 1,800 patients with cancer of all stages in May revealed that 2 in 3 patients reported that their cancer care has been affected, and 1 out of 3 reported treatment changes. So these are significant issues. And overall, 31,000 fewer patients started treatment for cancer across UK compared to the same period last year between April and August 2020 and April and August 2019. So that's that, so how we are going to move forward. You can look at this, our manuscript here in delivering cancer care, as I said, and recommendation and lessons. And I'm not going to go deep into these issues because I'm sure each of the experts will be talking about it. And we heard from Dr. Mushabab about the Saudi national plan. But basically we have specific tables for what to do with a general recommendation to minimize risk for patients' infection, and then how to prioritize patients' care. Unfortunately, we should try to normalize things as much as possible. But those who are experiencing a second wave and their system is going to be overwhelmed, they are going to be facing resource limitations again. And they may have to, unfortunately, go back to the prioritization again, fact of life. But the most important thing, we need to minimize the interruption as much as possible. We have to take care of the healthcare team. We have to take care of our oncologists, our nurses, our staff, because they are paying a big toll and price from this, and they are very essential to care for others too. We have to take care of them and take care of their families too. So, because in our survey, actually, we find that many of the cancer doctors worried about transmitting the infection to their families. And, so that's very important issue. Clinical research, that's something, need to be discussed separately, but there are issues here, what to take care of. And we should have now in the cancer centers and in every healthcare facilities, hospitals, and so on, part of their recovery plan and always preparedness plan, we should have different components, making sure that the care comes, during crisis in as a smooth way, as predictable and controlled way as possible, knowing that there are variables that you cannot control, but at least there should be a preparedness plan that is always documented and disseminated among staff to know how to act when things get tight and tough. So, conclusion, cancer care was affected widely by the pandemic, from screening all the way to palliative care. There is a new normal of cancer care that we should assure maintaining cancer care on track as much as possible with maintenance of precautionary measures. What should we do in the region? Let us please make sure that we share our experience with the rest of the world. I had the honor to be the only member in the from outside the US in the steering committee of ASCO registry. And in collaboration with ASCO, we brought this ASCO registry platform to have a global COVID-19 registry that will be managed from Saudi Arabia. Please, if you are interested in joining, so we have now multiple sites from Saudi joining us and multiple countries in the region, but this is a global registry. It can be also from any country in the world who is listening to us. So you can reach out to me and I'll be happy to work out with you all. By this, I will stop and I'll be looking for any questions or discussions in the QA session. Thank you.